It is another roundtable discussion of medical questions from a variety of sources. Our panel of doctors provides the answers. The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Good day, and welcome to On Call Television. This is the first show of the 11th season for On Call, our weekly panel conference on healthcare information. In a world of misinformation where marketing drives too many sources for medical facts, On Call makes every effort to share science-based knowledge coming from medical experts who profess an honest and ethical perspective. Although this first show is pre-recorded and not live, I promise, starting next week, we will once again be taking your phone calls and answering them live on air. The topic for this week is Ask Anything, and to obtain questions for our two experts, we went to the South Dakota State Fair, to a clay pigeon shoot, and to a sailboat trip on the shores of Lake Superior. This week, we are attending the medical meeting of the South Dakota chapter of the American College of Physicians and have corralled two of the experts attending the meeting today. Trained at the Washington University School of Medicine in St. Louis, Missouri, and then his internal medicine training at Strong Memorial Hospital, University of Rochester, New York, Dr. Tom Tape is an academic general internist, now a full professor teaching medical students and residents and at the University of Nebraska, Nebraska Medical Center in Omaha, Nebraska. Tom is presently the chair of the Board of Governors for the American College of Physicians. He has a special interest in information systems, medical judgment, and how physicians can find help in making medical decisions. His special interest is photography. Trained at the University of South Dakota School of Medicine, now Sanford School of Medicine, and then his internal medicine and pediatrics training at Marshfield Clinic and St. Joseph Hospital in Marshfield, Wisconsin. Dr. Matt Bean both practices med-peds at the Avera Medical Group Brookings and also is Associate Director of Medical Education at the Sanford School of Medicine at USD, teaching mostly medical students in Sioux Falls. Matt has a similar interest like Tom in information systems and decision-making. His special interest is running and is the race director for the world-famous Brookings Marathon and Half Marathon held every May in Brookings, South Dakota. Welcome, gentlemen.
Thank you, Rick.
So, Tom, tell us a little bit about why you're here in Sioux Falls, now at the Avera Cancer Center. What are you doing in Sioux Falls up from Nebraska?
So I made a special trip up from Omaha at your invitation to speak at the South Dakota chapter of the American College of Physicians meeting.
All right. Tell us about the American College of Physicians.
So the American College of Physicians, for short is ACP, is an organization of physicians who practice internal medicine. It was founded almost 100 years ago in 1915 and has now grown to be the largest organization of specialty physicians in the country at about 133,000 members. And there are chapters in every state of the United States as well as international chapters in Canada and Mexico and a number of South American countries, Japan, Saudi Arabia. We're really becoming an international organization, even though we started in the United States.
And what was the mission of this organization? I mean, what is this group of internists and subspecialists that are internists? What is it supposed to be doing?
The mission of the organization is to foster excellence in the practice of internal medicine, put very simply. We have a big component of education of physicians, education of patients, the public. We also do a lot of work in the area of advocacy, seeking a better healthcare system for our patients.
So it's patient-oriented.
It is very patient-oriented.
Okay. And Matt, you are also involved with the American College of Physicians. Tell us your spot.
My involvement has certainly been on a more local level with the state, and I am currently on the council, serve on various committees with the ACP in South Dakota, and this year I'll be attending the meeting here in Sioux Falls as well.
Great. And what is MedPeds? Tell us a little bit about MedPeds. I mean, people understand family physician. Is that close to a family physician, or what is it?
Similar. I think, I went through both an internal medicine residency and a pediatrics residency. They just happened to combine them together and shorten it by a year or so. So I ended up having a board certification in both specialties. So instead of just seeing adults, I also see children, and my training probably was a little more involved with some of the more acutely ill children throughout the 4 years of my residency.
Okay. And this is not a live show. We're doing it a day before the show. So what we are going to be doing, though, is taking these questions from all over the state, and we have we're going to start with the first questions, unless there is any other start. If I can get this pointer to work. The first question has to do with red wine.
Can you drink too much red wine?
Okay, that's a good one. What about red wine? What's your comments about red wine and drinking too much and healthcare issues related to wine drinking or alcohol in general? Tom?
I would say everything in moderation. Okay, too much of anything is a problem. You can drink too much water and make yourself sick. But particularly with any form of alcoholic beverage, in moderation, okay. Excess, problems. And in particular, the red wine question, if you're susceptible to migraines, it's really a particular problem because some of the components of red wine are a particular trigger for migraine sufferers. So more than just its alcohol content, there's an issue with red wine.
Let's sidebar off of, and we'll go back to alcoholism in a minute, but there are certain foods that you can't eat or drink if you have migraine headaches. Matt?
Certainly some of the wines, there's various aged cheeses that can do that. Caffeine can go both ways. Probably best to just review that whole list with your doctor so you can hopefully prevent as many exacerbations as possible.
Yeah, I've heard orange juice. I've heard aged meat, like pickled fish, that kind of a thing. And chocolate has been known to be part of that. Like you say, comes and goes. Some people say that the chocolate and the caffeine are good and help with it. Some people, it makes it worse.
Too much sleep, too little sleep. The bottom line is each migraine sufferer has got to figure out what his or her own triggers are. So what I encourage my patients to do is to keep a diary.
See what it is that triggers
See what it is that's triggering your headaches, and then you can eliminate those particular issues from your lifestyle.
I've heard one other comment about alcohol. Almost all of the alcohol drinks that you can have will make migraine headaches worse except for vodka. Have you heard that one?
I've heard that, but only from patients, so I don't know if there's any evidence for that.
I heard a doctor say that. I can't remember who the doctor was. He says, of course, don't mix vodka with orange juice if orange juice is a problem for you. So you just drink it straight or whatever. I don't know. So do we want to make any comments about general alcohol in general? There's a lot said about the health benefits.
I think going back to the red wine question, it's certainly a very kind of timely topic. There's been some kind of questions raised about the research behind red wine and whether those other ingredients in red wine are really helping us as much as we think. all of those studies are sort of retrospective studies, meaning they kind of look back and say, how much red wine have you had? Are you healthy? And they try and draw associations. But the prospective studies really haven't been done to prove the benefit. And I think if you put all the studies in general together, it looks like there is some benefit. But again, back to your comment on moderation. 1 to 2 drinks for men, probably up to 1 drink a day for women would be okay.
And I think in my personal data, because my belief, as you read everything through your years, I believe that it does have it's alcohol. I don't think it's necessarily red wine. And I think it has a protective effect, but it's so destructive for certain people. So we really have to be careful about making blanket recommendations. We have another question from Dr. Peckus. He's an ophthalmologist who is we were on Lake Superior at this point. Here's Dr. Peckus.
I have a chronically terrible back. I've had surgery on it, and I had fusion, and I exercise religiously and do Pilates, but it still bothers me. And I think what's happened is that now I've got an area of stenosis superior to the one that I had, one vertebra up that I had before. So I'm just trying to deal with it. You have any tips?
So that's a great question. A lot of people that come to general internists have chronic back pain, some of which have had surgery, some of which have not. Any general comments about that, Matt?
Well, I think even before you get to the chronic point, those patients with acute back pain, I really do try to be very conservative early on. How can we control the pain, manage symptoms, but try to avoid a lot of expensive imaging, certainly avoid a lot of invasive procedures or surgeries early on, because the vast majority are going to take care of themselves over a couple months. So it's difficult. Patients want things done immediately, and it's really hard to convince them of that. But that's certainly my first step with back pain, is to really hold off on anything real expensive or real invasive early on.
I absolutely agree, and in fact, one of the initiatives of the American College of Physicians is called high-value, cost-conscious care. And the idea is to try to identify interventions that don't tend to bring much help to patients, but are either risky or costly in imaging for low back pain in its early phases without any kind of red flag symptoms that would make you think something more serious is going on, is certainly one of those areas where if that's something that is being talked about, I think you should ask questions.
Yeah, I like to say it's the physical exam and the history that is 90% of it, and an MRI or a CAT scan is that extra 10% and is actually preoperative.
Right.
And so a good doctor or a clinician is going to examine the patient, take the history very carefully, and the last thing you're going to be doing is those imagings. And think about the surgery. Surgery is good when you're losing nerve function. It's not very good for pain.
And I think the challenge is that people would like to believe there's a very specific, I can pinpoint this cause of my back pain by taking a picture of it, and we know that's not the case. And in fact, if you take advanced imaging of apparently healthy people without back pain, you find plenty of things that look pretty scary on those pictures.
It would make you take them to surgery.
Exactly.
Except they have no pain or problem.
Exactly. So we now believe that having those incidental findings might have nothing to do with the pain a patient's suffering. So let's not find those things out that are going to lead us astray. Let's keep our eye on the ball.
Okay. Anything more to add?
I guess comment on the chronic pain and the people that go beyond the acute pain. What can they do? I think that quick fix of surgery is what people want, but when you look at the big picture, it's probably more than just that little bit of back pain. There's probably an element of weight loss. There's probably an element of other healthy lifestyle changes, other things that they're going to have to do in order to long-term be free of pain. So it takes a team approach.
I think about the pain that comes after an orthopedic surgery that happens when you don't get them moving very quickly. They get a post-operative chronic pain syndrome sometimes that they never can pull out of. And that post-operative pain is prevented if you get them moving, you get them using it, and it is the using it and moving that seems to prevent the problem down the line, and the less you do, the more it seems to accelerate the pain. We have a question about red meat.
I'm kind of wondering if I should limit my red meat intake.
So he's thinking that we should limit his red meat intake. Now, what's your take on
from
that?
Nebraska. I have
Hey,
a conflict of interest. I can't answer that question.
I grew up on a farm, so I may have a conflict of interest as well. but
I
do
don't-
have a comment.
Oh, yeah, okay, let's hear it.
I would say that, again, going back to Tom's comment, all things in moderation. I mean, there's definitely some good things about, potentially good things about meat. It's rich in iron, it's rich in protein. It also comes along with fats and cholesterols. So again, small portion sizes, maybe not having meat every day, but I'm certainly one that is a proponent of beef overall as part of a healthy diet.
All right. And that's where you're at.
Well, driving up here, I passed a cattle truck, and right on the back of it, it said beef. It's what's for dinner.
Yeah.
So what can I say?
I'm from South Dakota, and my comment is that even in the nutritional journals that I read on a regular basis, they talk about the fact that now it looks like it's carbs that's really more detrimental to your heart and your vascular system, and it's the sweets, it's the excessive carbs, it's the diabetic-inducing problems, and that we're better off. Even weight loss occurs quicker in the studies showing people going on a low-carbohydrate diet. And so I've changed my thinking about it. It isn't really the meat, it is the quantity of calories and maybe the avoidance of excessive worked carbohydrates.
Yeah, I'd agree. And one of the things that I've found curious over the years I've been in practice is how much dietary advice has been dispensed without any science behind it. And it's not that it didn't make some theoretical sense, okay? This idea of we should eat a low-fat diet because we are what we eat, and if we eat fat, we'll get fat. But we now know from better and more recently done research that you can actually get fatter on carbs than eating fats. And so it may be more important to think about the types of fats you're consuming and the overall distribution of fats and proteins and carbohydrates than it is to focus in on any one thing as the culprit. And I go back to agreeing with Matt said, it's everything in moderation, balance.
What about processed food? There's a lot said about processed food. I mean, processed carbs we've just talked about, but in this American diet where you go into the grocery store and instead of going on the outside aisle where the fruits and the vegetables are, you go through the middle and all these processed foods. Do you think that's harmful, or does it? We're going to say the same thing you just told me.
No, I do think if you look at the data, people who eat foods that are less processed seem to be healthier. And so given that we might not know all the answers behind that, I'd err on the side of eating the fresh foods and things that are less highly refined. We certainly know with things like rice, for example, that white rice really causes a spike in a person's blood sugar. And so eating brown rice can temper that a little bit. Right. So I think that's good advice, although I agree with you. I don't think all the science has been worked out there yet.
No.
I think the problem is that the calorie density and the sodium density and everything just rises exponentially the more processed you get. Unfortunately, a lot of those foods are also a little bit less expensive, and maybe people tend to buy those for that reason. Plus, they're sweeter and saltier, and we've just developed a taste for that.
Well, and we have supported corn growing, and we have by our legislatures, and so we've made a lot of corn sugar pretty cheap, and that's been part of all of that.
Just put it in gasoline.
Yeah, probably a better way to do it. What about the question of antibiotics in animals? And there are those who say that we do too many antibiotics and it causes resistant organisms, and there is data to say that there's more antibiotics given to animals that are not human than there are to the human animal. What's your comment about that, Matt? You're a pediatric-oriented kind of a guy.
Well, I mean, if you look at it from the perspective of production and cheap production of animals and their products, I mean, antibiotics have just become part of the culture, and it's very hard to extract that from the culture. In an ideal world, you wouldn't have that, but I think it's pretty simplistic to say that we can just eliminate antibiotics in agriculture. But do I think it could be better? I think it could be better. There's no question.
And should that be legislated? Is that something that we should legislate? No comment.
Well, I don't know enough about it, and I think one of the important things is that we try to work from evidence and science, not from politics. And so I'd want to know more about the problem before trying to make a recommendation along those lines. I will say this, that during the time that you and I have been practicing medicine, it's only gotten more difficult to deal with infectious diseases because the antibiotics we had available to us back in the day, the wonder drugs, aren't so wonderful anymore for a lot of infections. And one of the theories is too much use of these same antibiotics in animal feed.
MRSA, methicillin-resistant Staph aureus. Well, and not only that, but now we have overgrowth infections that are occurring in people's colons that are killing them. Clostridium perfringens, people have diarrhea that's just unrelenting related to our antibiotics. Comment. Putting you on the spot. Any comment about C. difficile infections, Matt?
Well, it's just another representative organism that's found a way to evade more and more of our antibiotics. And the more we use, the more they figure out ways to work around it. And that's just the way life happens. So I think the less we use antibiotics unnecessarily, the better. There's no question.
Right. But that's a great example. C. difficile was not a known problem when I was in medical school.
No.
It surfaced when I was a resident. Yeah. And it was very unusual.
Yeah.
Today it's very common.
It's everywhere.
It's everywhere.
It's everywhere. This is the Avera Cancer Center that we are presenting. We were going to do it outside, and now we had the rain. It's amazing. I wonder if we would do this more frequently. Plan it outside, we would bring more rain. We need to remember.
Are you asking me to come up every week?
Yeah. So the Avera Cancer Center, thank you for letting us do this here. If we have some extraneous noises here and there, it's people are actually using this building. We're about halfway through the show. I thought we would take the next question on thyroid.
How would I know my thyroid isn't working well?
So let's talk about thyroid disease. What are the symptoms of low or high thyroid, Tom?
Well, the symptoms are nonspecific.
Nonspecific
that means
meaning?
They're vague. And so the commonly cited symptoms are fatigue, cold intolerance. I feel cold all the time when other people tell me that they're comfortable.
And that's when the thyroid is low.
That's when the thyroid is low. Subtle changes in the skin and the hair, possibly some weight gain. But the fact of the matter is you can't really distinguish those from people that have healthy thyroids without doing some blood work. And so you have to actually measure the level of the thyroid hormones and the hormones that control the thyroid level to really figure out what's going on. So what I always tell patients that bring it up is, since you thought of it, we're going to check it.
Yeah, that's my comment too. Matt?
Well, the other opposite side of that is an overactive thyroid would have kind of the opposite symptoms. So heat intolerance, feeling warm all the time, losing weight unexpectedly, maybe an excessive perspiration, a fast heart rate, something like that. A lot more rare than the low thyroid, but certainly something that we think about when patients come in with those symptoms.
Yeah, you see that in a younger person, maybe sometimes with a lump in their neck or a thyroid nodule. You see this low thyroid, though, in pervasive. I mean, and it seems to occur more as you get older and more in women. And it's probably 10 times, 20 times as common low as it is in that it's high. So his question was, again,
How would I know my thyroid isn't working well?
and it's a blood test, is it? Right. So that's a good, any other comments that we should ask about that? We have a question here.
My question is, I use a lot of game calls, both plastic and wood, and from season to season, I'm wondering what's the best way to disinfect them so I don't have them sitting around between seasons building up germs like a petri dish.
Okay, so he uses game calls. I mean, you know, that's, you know, duck calls and all sorts of animal calls, and he honks on them, and they're in his mouth, and, you know, does he need to clean them or disinfect them? Or, I mean, what about toothbrushes? What about other things that, pens that people put in their mouths? A lot of things people put in their mouths.
I would argue minute to minute, hour to hour, he may want to worry a little bit about that. Season to season, I mean, just leaving them set, there's very little that's going to live for very long. Once that dries out, organisms just don't survive on it. So I don't think he needs to worry so much season to season. How would he disinfect it to share it with someone else who's going to call? That's a little trickier. Certainly soap and water does wonders for things if the devices can tolerate it. Otherwise, an alcohol-based solution would probably be the best.
Yep, that's a great
I'd say an alcohol wipe, if it doesn't ruin the device.
Great question.
Yes, I have a question on frequent headaches. Wake up in the morning with a headache and wondering how much aspirin or Tylenol or Aleve a person should take each week.
So headaches is one question. The second is, how much pain medicines should you take?
Well, the first thing I'd say is if somebody's taking a lot of aspirin or acetaminophen, the ingredient in Tylenol, I'd wonder if the medication doesn't have a role in the headaches. So there's this idea of what's called rebound headaches, which is every time the level of the medication you've been taking quite a lot of starts to drop, a headache comes back. And one of the typical signs is people who wake up in the morning with headaches.
That was one of the two things I immediately thought of, is that drug level in his system is dropping. He's got this rebound phenomena. As soon as he takes more, he gets better, but by the next morning, it'll be right back again. So certainly that. The other thing I thought of with him having headaches in the morning is there a component of sleep apnea? And you can see that with sleep apnea as well.
Ooh, great answer. I do think exactly about, we think, people think that these pain medicines they take are helping them. They need to take them on a regular basis. And in my history of prescribing years ago, before either of you were practicing, I'm handing out non-steroidals like crazy. I'm really pushing it, thinking I can avoid arthritis of the knees and prevent the progression of osteoarthritis by using anti-inflammatory agents. We found that it didn't work. It didn't change the progression. But now what we've got is people who can't get off these medicines because they have severe headaches. And in fact, they have headaches all the time because they're on them.
And just to caution people a little bit, I don't think they have to stop daily pain medicines they're using for arthritis if they don't have headache problems. I mean, it may be giving them some benefit, but people who are using daily pain medicines for their headaches could be having the very same problem we discussed.
And unfortunately, you really do have to get off the medication. So there's a period of time it's pretty miserable.
Right. And you don't take another pill.
That's right.
To help. You just have to withdraw. It's interesting. I've had rheumatologists on my show, and they say, not a problem. Use the nonsteroidal. You've got to be careful, but let's use the medicine. And I've had nephrologists on my show who say, don't touch the stuff. It causes your kidneys to cause problems. And I think the reality is that I have moved in the direction of using plain old acetaminophen, which is also Tylenol, a lot more as far as encouraging people to use that as an occasional rescue, but not as a regular pill. And that's where I'm at. Try things as a rescue, try not to use them scheduled. That's different than what I started out many years ago.
And I'd also point out to you, Rick, that the reason that the rheumatologist doesn't see the kidney problems is the patient goes to the kidney doctor, and then the ones that don't have kidney problems don't go to the kidney doctor.
Yeah.
So, I mean, there's a little bit of what I call a filter going on here, where if you're a specialist, you don't see the people that don't need your services.
That's right, and that's the advantage of the future, encouraging more people going into general internal medicine or primary care, because you get that whole perspective. Here's a question that's, I think, quite revealing and interesting.
Just one question. What is lupus? I have a friend who has it, and I know she suffers at times, but I'm not familiar with the particular disease.
So let's talk about lupus erythematosus, or systemic lupus erythematosus, versus... Yeah. There is a focal lupus. Tell us about that.
Well, I think that probably to just put it in perspective, lupus is in that broad category of diseases we call autoimmune diseases. So our body is actually creating an antibody against itself. And with the focal kind of skin lupus you describe, it's an antibody against a protein in the skin. But the more common lupus would be this systemic lupus where multiple organs are affected. And the range of symptoms, you name it, it can happen with lupus.
It's anything. And the cause is really what?
No. It's what Matt said. It's the body producing antibodies against itself, but why would it do that?
Right.
We don't know.
Is it a viral infection?
There probably is some genetic predisposition and some environmental trigger that come together in the right patient at the right time, and this condition arises from that.
Okay. We have actually a female question.
How do you know when dieting turns into anorexia?
Oh, well, let's talk about anorexia nervosa. What is that?
Well, this is a question of degree, I think, to answer your person's query. So it's dieting beyond what would be healthy, and the hallmark, in my experience, is a patient who is very thin but perceives herself to be overweight. In other words, dieting is fine when one is overweight, but one loses perspective of one's own self-image and perceives that, in spite of the fact that the person might look like they just stepped out of a concentration camp after World War II, that they're very, very overweight and can't eat anything. And so it's dieting to the point of illness, of really an unhealthy nutritional status.
That's your territory too.
Yeah, I think there are some specific criteria where the BMI, or that body mass index, is below a certain point, 17 or less. But what the patient will typically experience is, beyond that significant weight loss, is things like loss of their period. So if it's a female, they won't have their regular monthly cycle any longer. Basically, it's just an energy deficiency overall for the body. So things start to shut down.
And you're saying that it occurs more often in women?
Definitely more often in women, not exclusively, but certainly more often in women.
And what's the age bracket that you commonly see it?
I would say probably the younger women, sort of teenagers into the 20s and 30s, would be a little more common.
Do they excessively exercise? And I'm not criticizing exercise, Matt.
I think a person with anorexia and bulimia, another kind of associated disorder, both use a variety of methods to maintain that weight loss. So it could be simply this caloric restriction, eating very little. It could be excessive exercise. It could be inducing vomiting, inducing diarrhea. There's a multitude of ways.
Now, we know that Karen Carpenter died with this illness. Was it related to an overdose of a medicine that makes you vomit? Is that what happened?
I would say that the ultimate cause of death for a lot of patients is typically some sort of heart arrhythmia, but that stems from an electrolyte disturbance or some other, the malnutrition goes on for long enough that, again, normal bodily functions start to quit, and one of the main ones is a heart rhythm problem, and that's probably what she ultimately died from.
So now you did talk about bulimia, which is the vomiting. What is the difference between anorexia and bulimia? Are they the same kind of psychodynamics? Do you know?
I think there's still that body image issue that Tom mentioned. Bulimic patients tend not to be the super, super thin patients. They tend to control their weight by maybe overeating or binging and then purging somehow, dieting excessively, exercising excessively, but they oftentimes aren't those real low body weight people like the anorexic patients are.
They'll put their finger down their throat and purge or vomit, right?
So a bulimic patient is going to be less obviously ill, say, in a public setting. In other words, people aren't going to look at a bulimic and say that person must have an eating disorder, whereas if you see somebody who's emaciated that has anorexia, you'd say, gee, there must be something wrong with that person.
Both very difficult to treat.
Yes.
I think that's one comment I would make, and it's something that, again, kind of goes back to, it takes a good history to find it, especially in the bulimic patient, and you really need to get a team approach with a therapist, maybe some medication to help them through that.
My heart breaks for these people, and there may be, or there will likely be, a bulimic or an anorectic person watching this show right now. What message would you want to leave them?
See your doctor. Get help.
Get help.
It is a complicated problem, and it's
life-threatening.
It is life-threatening.
Yeah. We have another one. Here is from the fair.
Is there any side effects for being on a acid reflux medication permanently?
Acid reflux medication. Well, there are two major categories of acid reflux medicines. What are they?
Well, the original was just the antacids way back.
Melox, Mylana,
Tums.
Okay, and Tums. Those are three.
Relatively newer than that are the histamine blockers or the H2 blockers, like the Zantacs, the Pepsids.
The cimetidines.
Yeah. Newer than that, of course, the most commonly used one now is the proton pump inhibitors, the Prilisecs, the Nexiums, the purple pill that people hear about. And I would say significant reflux or significant acid problems almost always require that level of treatment.
So it's been a huge boon to healthcare and to patients who have reflux to be able to treat it with these medicines instead of surgery. I mean, when I was being trained, we were learning how to cut out ulcers, change the anatomy of the stomach, and treat people who have these terrible bleeding, life-threatening illnesses with surgery. Now we don't do it at all. I mean, it's changed.
One of the more common operations used to be done, right?
Yeah, it was
Bill Roth too, V&P.
Yeah, that's right. It's gone.
It's gone.
Because of these medicines. So they're huge in helping people. And I know when I was in years past, and presently I'm on a board for pharmacy and therapeutics, we know that even when the patient had to pay for the pill and it was expensive, they would pay for those pills because it was so important for symptom relief. But this man's question is, do they cause problems?
They're a double-edged sword.
What are they?
Every medication we take has got
medicine.
good effects and it's got side effects.
Unless there's no effects.
And I think the answer to this question is gleaned from listening to the advertisements for these different medications you see on TV. They tout the benefits very clearly, and then there's this very quick narration that you can barely follow that lists all the side effects. And the thing that worries me the most about the most potent pills, the proton pump inhibitors,
the Nexiums, the Omeprazole, the Prilisecs,
is these are the medications that predispose people to things like C. difficile, this terrible diarrheal infection that you were talking about. And so my advice to patients is take just enough of these medications for just enough time to deal with your problems, then try backing off. As you mentioned, we've got the H2 blockers, which are less potent and have less problems. And then if all you need is an occasional Tums, well,
maybe that's the better option.
That's the safer way to go. So you use just enough of whatever potency of medication you need to control your acid symptoms.
Okay, but I'm going to disagree with you in some sense.
Good.
All right. My patients are, I have a lot of guy patients. South Dakota guys, they don't complain. You know, they bear with a fair amount of discomfort. And if I suggest to them, and I have, the same line of, well, the less medicine is the best medicine, they'll come back to me a year later and say, well, you know, I've got a fair amount of heartburn, but I live with it, doc. I don't need that. And they end up with reflux that is dangerous to the health of their esophagus, and esophageal cancer risks come up. I know.
I certainly wasn't recommending that.
No, I know you aren't.
So don't suffer in silence, in other words.
That's it. And I think that this C. difficile overgrowth problem, or a little bit of pneumonia, there's an increased pneumonia in people who take a lot of that. It's a lot smaller than the major problems that we got into without those medicines. So we have to be careful about the balance. Any comment, Matt, about how fast to stop?
Well, I think that was a comment I was going to make, is people who try to wean themselves off maybe do it too quickly sometimes, and there's actually a rebound effect. So now you've suppressed this the body's natural response is you take away that suppression, is boom, that acid comes back in threefold, and they get their bad symptoms back. Whereas if they'd have taken it maybe every other day for a month or two, the body would have slowly kind of gotten used to being without the medication, and maybe they don't have the rebound, and they can wean off the medication.
Right. Up to 3 months to wean off these medicines.
I'd agree with that.
But that's scary too, if you think about it. I mean, even people who didn't have acid reflux problems were started on omeprazole or Nexium or any of those, just testing, and then subsequently they stopped them and they had reflux. They didn't have it before. They had no acid before, and now they have acid problems. So we have to realize that it's sort of like the heroin story of you get started on, you can't get off of it. But it isn't.
The misconception I would say about these medicines is how quickly they work. So you see the ad on TV, you go out and buy the proton pump inhibitor, and you take the pill, and an hour later, you aren't any better.
No.
These are slow to act. You got to take them on a regular basis for a period of days before you're really going to get their full effect. So I recommend for people use those older antacids like Maalox or Tums or whatever for fast-acting relief. Give the newer pill a chance to do its job, but don't expect instant results.
Well, and I like ranitidine, which is Zantac, or Pepcid, famotidine. I suggest those as the faster rescue if Tums is not enough, because it's a lot faster. Use it as a rescue, just like Tylenol for pain. I mean, you know, as a rescue, not as a regular. We have another, well, I got another question.
So what do you think is most important? Addressing heart disease and just general health as you become older in life.
What do you think are the most important general health methods, particularly in preventing coronary disease or vascular disease? What can we do? You know, we all grow old and we're going to die one day, all of us. Most of us die from a clot in a vascular system. You know, that's, a heart attack or a stroke or a kidney that wipes out with a vascular disease. How do we prevent vascular disease?
Why don't you ask the runner?
Let's ask the runner.
Well, I think it ends up being just a combination of lifestyle choices. And I think maintaining a healthy weight, dietary moderation, exercise even in moderation, but trying to incorporate some exercise in most of your daily activities, I think are all important as far as your heart health long term.
I also think it's important to emphasize that while a healthy lifestyle is probably the best steps one can take, what you're born with in terms of your genetic predisposition to heart disease has a lot to do with it. And so if you have genes or family history that suggests you're going to have premature heart disease, even if you do everything right, you may not be able to head it off.
Right. I think the important thing too, myself, is that if they've got sleep apnea, that's a hidden bad thing that really will, if you drop your oxygen level, to half through the night, off and on, or you don't get decent sleep, people get into big trouble. And I think that's the big bad part of obesity, because they don't get enough oxygen.
And they don't realize it.
And they don't know it. The other thing is, I personally think there's I'm hopeful, but not scientifically proven things about vitamin D. We know that low levels are very dangerous and high levels seem to be protective. We don't know that giving them vitamin D makes a difference. What are your comments about vitamin D?
Have another hour? We actually have a vitamin D expert in our Nebraska ACP chapter, and so we've actually had him give talks at our meetings a couple of times, and it clearly is an area that we're just beginning to uncover some of the many ways in which vitamin D may be helpful. We traditionally think in terms of vitamin D controlling bone health and calcium metabolism, but it's apparently much more than that, and it seems to have beneficial effects on the heart, beneficial effects in terms of preventing infections like influenza, may have some beneficial effects on cancer. The problem is nobody yet knows what is the optimal dose to achieve all of the spectrum of benefit of vitamin D. And the national guidelines that were issued about a year ago recommend a fairly modest intake, lower than I think a lot of people are taking.
Yeah.
And some physicians are saying, well, we know that the drug is safe up to a pretty high level.
Right.
So maybe we shouldn't be so conservative in what we recommend. And so at the end of his talk, the first question was, well, how much should I take? And he gave a waffling answer like I'm giving now. And then someone said to the next question, well, doctor, what do you take? And his answer was 2,000 units a day, but I have to say, in all fairness, that's almost 4 times what the recommended dose from the Institute of Medicine that issued these guidelines.
You know, the Institute of Medicine has to be very careful about what it recommends. I mean, it's been asked to push all these vitamins all these years, and it knows that you need to have 4,000 in kids and so on and so forth, and then 6 and then 8 for elderly. 400 and 800 for the elderly is their recommended. Make sure everybody gets that. But they also said less than 4,000 is safe, and probably less than 10,000 a day is safe. That's what they said. So I take 2,000 a day.
Okay. So
and I exercise on a regular basis, including I walk a mile a day. If I'm not working out, I'm walking a mile a day. Every day I do an exercise thing, and I think that is the most important thing for your vascular health. If you take a diabetic, what are the things that make a difference for a diabetic? Because that person is the higher risk for vascular disease. It's the weight control, it's the regular exercise. I think the vitamin D, and
one thing I'll add probably goes without saying, and that's smoking. I mean, there's no question. There's one lifestyle choice anybody that's smoking can make, and that's stop smoking. There's no question it's going to be a benefit.
I agree.
Very good point. Okay, one more before we end. Here is from the fair.
What are the newest treatment forms for acne, and what's the easiest way to get rid of acne?
Ooh, what's the newest treatment?
Sounds like a great MedPeds question.
Yes, it does. It sounds like a MedPeds guy.
Boy, I don't know that there's anything cutting edge new out there. I think, again, genetic predisposition plays a big part in acne. It's not simply a matter of just keeping the face clean, but certainly
it isn't clean.
Not just keeping it clean, but that can play a part. Beyond that, there's a combination of treatments that involve unplugging the pores and another to keep the bacteria count down. So there's probably a combination of some topical things that people can do over the counter for the milder cases. The next step is some of these creams that unplug the pores. Beyond that, oral antibiotics, again, a little controversial because of the antibiotic resistance, but certainly beneficial for acne. And then I guess one of the relatively new treatments would be this Accutane medicine that actually gets to the core problem in acne of the oil-producing gland and how it works, but potential side effects with that medication as well.
Right. So you said, you suggested some words, but there are over-the-counter equivalents. Now, the antibiotic you're talking about is either minocycline or doxycycline, which I think are readily available, but with prescription. But the other 2 kinds of medicines are available over the counter. What are they?
Well, most of the over-the-counter contains something like a benzoyl peroxide or a salicylic acid that make the skin dry out a little bit and turn over quicker. And again, that helps to unplug the pores, plus benzoyl peroxide probably has some antibacterial component to it as well.
Benzoyl peroxide, and there's a variety of but there's some generics available. You could look at the prices and consider using the benzoyl peroxide. What else?
Boy, it's really tough to generalize acne. I think it probably does take a visit, beyond the mild cases, a visit to your doctor to kind of walk through those steps with you.
Okay, and you know, the issue of Retin-A or tretinoin, which is a prescription drug. What's your comment about that?
That goes back to that cream that I mentioned that helps unplug the pores. It helps the skin turn over quicker to get those plugs out of the pores and less likely to develop acne.
I want to make a comment about what a joy it is to have the 2 of you here, and again to say, yay, rah, American College of Physicians. What a wonderful organization. I'm proud to be a member and part of this, and they do care about the patient first and quality.
Now, you didn't tell us about your role in ACP, Rick.
Well, I was the governor. I'm no longer the governor. I'm a has-been governor from South Dakota. I'm proud to be
Governor Emeritus.
Yeah, I'm now the Governor Emeritus. So we want to thank Avera again. This is the Avera Prairie Center. It's the cancer center, and it is a marvelous building. And
Beautiful facility.
Really happy to be here. The computer age has finally dawned upon the practice of medicine. While the rest of the world has been living with electronic checkout, accounting, and business applications for quite a while, medicine has somehow escaped the plug-in, paperless medical chart until now. Why has the computer been so delayed in entering into the hospital rooms and private offices of medicine? Maybe it's because of the complexity of medicine, the potential risk of patient confidentiality, the time and cost required for physicians to learn a new system, or maybe it's just because of the stubborn nature of physicians. There are lots of possible reasons why the computer came late to medicine, but why did it finally come around? In recent years, as physicians' practices have been brought together into larger groups, electronic, portable, shareable records have become more inviting. Additionally, the government is strongly encouraging the electronic medical record, or EMR, by actually providing higher Medicare payments to doctors who are effectively using an EMR. The government is motivated by the belief that EMRs will reduce medical errors, enhance medical research, and set the stage for controlling costs, runaway healthcare costs. Indeed, there are more reasons an EMR could improve care. It gives immediate access to patient records. Old Way pulls old paper charts from large file rooms. It allows for readability of record. Old Way forces trying to interpret doctors' writing. And it provides for portability of records when patients move. Old Way copies reams of paper and mails them in bulk. But different electronic record systems don't speak to each other. The majority of systems are designed by computer programmers, not physicians. And every EMR system seems more written for billing departments and legal defense rather than made to enhance communication to help solve the patient's problems. But probably the biggest problem for the EMR comes, in my mind, from using checklists instead of writing out the patient's narrative. The computer puts us at risk of losing the valuable essence of the patient's story. Over time, I expect EMR systems will merge, will improve, and care providers eventually will learn to use this tool effectively. But it is still just an instrument to enhance, not replace or interfere with the important interface between patient and doctor. The computer is here, and we need to make it work. Gentlemen, we have 2 minutes left. We could talk about computerized medical record. I wonder if you'd make a comment about what I said.
I think it was very well put. I've actually been using electronic medical records in my outpatient practice since 1986. And I don't think... 86.
You've got to be way ahead of most people.
We actually implemented a system called CoStar, which was developed out of a federal research project way back in the 1960s.
Oh, it's a VA, through the VA.
It's similar to the VA system. They both use the same underlying medical programming language, but they're different products. And this system is, to my knowledge, not in use now, but it's been replaced by several generations of more advanced products. But the idea of being able to access my patient's records, no matter where I am, they can call me at home, I can look in their chart, I can be traveling in Europe. If I get an email from my nurse, I can look in their chart, make an intelligent response. That's worth an awful lot, I think. But as you said, it's in its infancy, and there's a lot of work yet to be done to make these computer systems that are more user-friendly and are going to help improve the care of our patients.
Matt?
I would just agree with your statement on it's here to stay. I think we have to figure out the way it can best enhance, not replace that physician-patient relationship.
We need to make it enhanced, do we not? Yes, we do. Well, thank you both so much for being part of this, and we'll enjoy our meeting that's coming up this next 2 days.
Happy to be here.
Thank you. And that's it for tonight. Thank you for joining us, and stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.